Please be reminded that during the presentations, you have an opportunity to present your questions in writing and hand them over to myself to be announced immediately after the presentation. With that, going further to the next presentation on regional anesthesia techniques and pain treatment in casualty patients to be done by Volodymyr Marcyniv, who is the chair of Intensive Therapy Unit in Feofania Clinical Complex. Dear Volodymyr, the floor is yours. Please hand over.
It's a great pleasure for me to be here and to be among our colleagues and so among the people who are fighting for the health of our people and for our warriors and for the democracy all around the world and all the and all of us with us, our American colleagues as well. So my presentation will be devoted to the pain syndrome as well as two previous one. I am head of Feofania Hospital. I'm head of department, the middle size, as well as we didn't accept any, and we accept the patient during the first months, people with acute further, but nowadays we are not do that. We perform the treatment of the patient not from the front line, but some delayed. And we've got the patient who are delivered in our hospital approximately in the period among 2 and 5 days, and stay in our hospital up to the normalization situation with the general status for 1 week or 2 or 3 months, and we accept not only the severe patient but the moderate situation as well, and we perform all the kind of surgery, and we understand that despite the great problem with the wound treatment and some mental health, we've got another situation. We've got another problem. It's a pain, and according to our personal statistics, if we estimate 2-point scales, the patient who are admitted to the hospital on the different stage of evacuation, they got a 6-point pain. And there is not only the one pain, that problem, that all of them, they are combined with a different problem, with the sleep deprivation, and moreover, all of them, they've got different kind of mental disorders. I'm anesthesiologist that is why I don't not specialize in the first one, but we mostly deal with the pain. Despite that, we are mostly dealing with the patient with a nociceptive pain, and we have a great technique to solve this problem, and we are really close to that. But every 12 patient has a neuropathic pain. This is a more severe pain, a more severe problem that could be chronicized and exist for a long time and disturb the normal situation for this patient, and could prove and only after even after the healing of the wound. There are two main aspects of this pain. This is post-amputee and complex. It's not so fast, but it's a great problem for to treat. We try to analyze the high incidence of neuropathic pain, as well as the two speakers said before. Unfortunately, on the previous stage of evacuation, our colleagues have no possibility to provide the right proper amputation. They're just going to save their lives, so they have any possibilities to no physical, no enough facilities, no enough time So that is why they have only to save their lives. And there are actually several different techniques that could prevent post-amputee pain syndrome. One of these was devoted to the previous lecture is the proper technique of anti-operation. This is really prevented this syndrome. And the next one is some regional blocks to prevent on the stage, and unfortunately we don't have enough this kind. And the next one is antidepressant, and the next one, the next problem that we face during our work, there are really few specialists who are dealing with the chronic pain. Actually, we even don't have enough specialists of this kind of specialists in Ukraine. So we are planning to provide the conference devoted to the chronic pain treatment, and we can count the specialists on the one or two hand the quantity of this patient. And whoever of the specialists who are dealing with this kind of patients, but I have to say that almost all of our hospital, civilian hospital, have the same quantity of the wounded combatant, and there are some specialists who are facing this problem: traumatologists, neurologists, and every these specialists who are dealing with this pain syndrome, and they should be informed regarding this pain treatment. And we do the same, and we establish the inner protocol for that treatment, and it's almost equal to our military protocol, and it helps us to treat this pain problem stage by stage for a wounded person. The main goals of this protocol is to create to treat the patient in such a way that will reduce the severity of pain, and it will get him from the treatment process. And moreover, we have to understand that all blast injury, there is not only trauma for one part of the body. The majority of this patient have the injury of different. So we have to provide a multimodal method to solve the problem and to treat it. And we decided to use different set of neuropathic, and one of them is physiotherapy, cannabinoids usage. But for us, for our circumstances, we are working out that the best way is a regional anesthesia. It could be different with catheter, with a single одного кола и введення, and we use neuromodulation and radiofrequency ablation. Some of them they are more effective, some of them less, and the reason to do that, we have to understand what is the best way for every patient. Regional anesthesia, you can see the photo of our citizen who published this book more than 100 years ago that was devoted to regional anesthesia. And what do we have in our arsenal? First of all, this is spinal, but it is actually very rare for usage. It's more useful for operation, but not for the operation, but not for the pain after the operation, and not for neuropathic pain treatment. Epidural treatment, it's more often used mostly for the pain relief of the abdomen and pelvis pain, because it's really challenging to reduce the pain and the circumstances of these injuries. Almost 1/3 of our patients got this kind of this anesthesia but the duration it could be even for some months, despite the fact that it's not recommended to stay more than 5 days. Peripheral blocks. This is actually our working horse to solve the problem with the pain in the extremities. And you can see some articles of our published by our American colleagues based on their experience in Afghanistan and in Iraq. And it was proved that pain with the usage of different regional pain for the wounded patient were much less, and the quality of life were much better. And that is why even based on our figures, and we perform much more single blocks comparing with these articles. And we use a single shot and catheter technique. Almost 80% of patients take a single shot at least, and sometimes for the summer patient, one patient got 26 block of one plexus of nerve. How do we perform that? First of all, we have to use regional anesthesia to understand does it work for this patient, and after that we input the catheter to input the medicine. Or if there is no possibility to do that due to infection of skin, so that is why we have to use serious single shot usage. Regarding the catheter peripheral block, we are using it right now very often, and the majority of these patients are used very often, and we're trying to stay it for the more prolonged period to provide the analgesia. There are some example of the blocks that provide adequate anesthesia, and moreover, we even that there are some way to modulation, and for the reduce, we can use sympathetic ganglion blocks, for example, Stilet. In the case of severe trauma of upper extremity, and moreover, if we block the more of low pain, and you can reduce pain, the post-amputee pain, and we're trying to perform that with ultrasound assistance because the lessen the time and less damaging for the personnel. It's all about, but there is, but we should consider that this is always not only one block, but it's a series of blocks, because it's impossible to say beforehand would it be just one, would it be the best, or what is the best way or the best technique. So we have to adapt our technique for every patient. And for the period when we observe the patient, we should provide the systematic approach, because the severity of the pain, it depends upon the surgical technique above wound healing. And that is why we have to provide a systemic approach, and it's really hard to provide it in our clinic. But a psychological service anesthesiological department in our clinic solve this problem in our hospital. And to make a road around, and we try to understand what is the best way, invasive or non-invasive therapy. And we perform the regular ward rounds with the different specialties, anesthesiologists, psychologists, and others, and try to adapt the therapy in the best way for our patient. And as far as a lot of specialists are involved in this process, and we make for us, you can see on a table like, and when we note all the data that that patient have, the severity of pain, the set of his problem, and all the personnel involved in this process use these tables. There is average data. How could we reduce the pain for our patient? As you can see from the very beginning, pain is equal to 6 points, and then we stabilize it to the 2 or 3, and only after 1 month later we can stabilize it up to 2 point. It's actually quite fine for the patient. In this process, we reveal for ourselves there is another problem in Ukraine to treat this kind of pain and to this kind of patient. Unfortunately, there is no a good connection, a good relationship between medical institution on the different stage of evacuation. A lot of hospitals, they have absolutely different approach, and a lot of doctors, they are really lack of knowledge to treat this neuropathic pain. And there is really often situation when the patient started to obtain the specific treatment, but after delivery in another hospital, they stopped this treatment, unfortunately. And so I announce our project Without Pain, and all the people who are working on this direction, and they will help us to systemize this pain revealing and the treatment. There is one case. The citizen of France, he's got neuropathic pain, and he has his arm and his lower extremities injured, and we perform neuropathic investigation, and here you can see the outlook of his wounds. Not so big, but his left palm was paralyzed, and it was a really severe pain that he complained of. This is a schematic picture of his pain and what we perform for 2 months of treatment for the whole period of his stay in our stationary. And we can say that the pain even enlarged after the admitting in our hospital, even beside the fact that he took heparin and in cannabinoids. But after that, we use regional anesthesia, in particular catheter subclavial block. And he stayed for 32 days, and we performed that sympathetic ganglion block as well, and enlarged the dosage of heparin. And he said that his situation was quite fine and healing of the wounds, but after some period of time with a dysfunctional catheter, he observed the enlargement of vein, and we add some special antidepressant drugs and enlarge with the different catheter. And he stays the next state for 19 days, and we have the much reduction of the pain after 50 days of treatment, and we reduce the dosage of pregabalin, and we took off the catheter. So you can see So you can see the clinical outcome and functional outcome for this guy after the adequate treatment. So, summary. What we have to say that pain after the combat trauma is a really significant problem, and we have to deal with that. And there is no way, it's impossible to find the easy way. And the good place for the treatment of this kind of patient would be the regional anesthesia. And as for me, this one of the most important things we have to do. This is providing the systemic approach to treat this patient. Thank you.
Дякуємо за доповідь.
Thank you. And we've got a question. Please, a really short question, a really short answer, and then we go ahead. Unfortunately, we are lack of time. Pani Volodymyr, great. Thanks for your report. Say please, on this structure of patient, is there any patient in this kind of patient? Is there a patient with a drug addiction? Was involved in the statistics of the reduction of pain from 5 to 2 by visual analog scale? Yes, you're absolutely right. We still have a patient with a drug addicted patient, and as you can see in our clinic, in our hospital, we're trying to use the opioids on the last place, but it's a really extremely severe patient. But we doing this in this way. We try to solve the problem with the regional anesthesia, and we're trying simultaneously to treat drug addiction as well. But we're lucky because there are a lot of these patients. So thank you so much. Great applause.